Good afternoon, everyone. We listened yesterday to wonderful presenters telling us about the great work done on the ground to reach out to people and how that work helped many individuals receive the care they needed, whether it's direct care or health-related needs to support them receive their care. We've also learned about the many challenges still surrounding hepatitis B and tuberculosis care. Today in this session, we'll focus on asking the tough questions as we address health equity and have an honest dialogue with our panelists on what our communities are facing today and their perspectives on ways to tackle such situations. We will start with some questions for our panel of experts. Then we will listen to a short presentation on framing of social determinants of health. After the presentation, we will transition into breakout rooms where participants will get a chance to have more focused conversations with the panel experts. And finally, we will all come back together to report on some of the key takeaways. First, I'd like to introduce myself. My name is Yasmin Ibrahim, and I'm a Senior Public Health Program Manager at the Hepatitis B Foundation. In my work with the foundation, I'm responsible for public health research and other duties, but currently we're looking into reasons for the underrepresentation of minority populations in health and hepatitis B clinical trials, while these same populations carry the highest burden of hepatitis B, and what are the access barriers to innovation and new medications as they are being developed. And although we are still in the beginning of the data collection, what we've learned so far is at the heart of health equity and social determinants of health. So I'm really excited and honored to be a part of this session today. I'm also responsible for patient engagement program, where I correspond with people living with hepatitis B from all over the globe through about 2,500 emails annually, answering their questions, thoughts, concerns, and feedback, or venting about the situations they face daily. A little bit about me. I'm originally from Egypt and currently live in Warminster, Pennsylvania with my family. I am a medical doctor by training and practiced for a few years in Egypt. And my experience with health equity in Egypt was different, as the set of social determinants of health is different than here in the United States and probably elsewhere in the world. So although there are lessons learned from every population and community and country, I learned that it is important to always think of health equity and the strategies to address it from a community-based context. Today we have a great panel of experts. I will ask them to introduce themselves and acknowledging that English is not my first language and that we all come from different backgrounds. Here's me pronouncing their names. Shioma Naji, would you please introduce yourself?
Yes, good afternoon, good morning, anything in between, depending on where you're at. My name is Chioma Inaji. I am located in Boston, Massachusetts, and I primarily do work around the intersection of sexual health, public health, racial justice, and immigrant rights. I've been doing particularly work with African immigrants and refugees over the past 20 years, everything from HIV and AIDS to health literacy to hepatitis B. So I'm excited to be in this space and have this discussion with you around how we can think about health equity within our day-to-day work.
Thank you, Shioma. Diane Randolph-Jones?
So I'm going to apologize both for my background and for any noise that you may hear. There was a bit of a blackout, so I'm making do. My name is Diane Randolph-Jones. I have been working in largely government, whether it's state or municipal or local government, for the past 20 or so years, working really on macro level interventions. For example, refugee facing someone may need to go on mute, so I'm just going to press a button that's asked to to mute. There's a little background noise coming in. But again, I've worked in government for the last 20 or so years, really worked on a number of different types of interventions that have focused on largely population-based supports. So for some, that has really been helping to integrate refugees and immigrants into the Commonwealth. And I'm here and I'm working out of the Commonwealth of Massachusetts, and have worked with veterans and a number of different types of populations. So I'm really excited to be here to be with like-minded folks who are really interested in being able to address address health-related disparities, again, with really smart approaches on a macro level.
Thanks, Dan. Dr. Cherie Poitier.
All right. Hi, everyone. I'm happy to be here. My name is Cherie Poitier. I'm located in Los Angeles, California. I'm a medical doctor trained in infectious diseases. I work for the County of Los Angeles Public Health Department and have done so for 20 years and heavily involved in COVID and monkeypox and other outbreaks, as well as about 50% of my time is involved in TB care and exposures and hepatitis as well. So happy to be here. Thank you.
Thank you for being with us. And Dr. Nia Itautu.
Aloha, my name is Nia Itautu. I'm coming in from Arkansas, but I actually do work in the U.S. Pacific Islands, Hawaii, and then all the states here in the continent. So I do a lot of work around, hepatitis B, TB, cancer, diabetes. So as you can see, I do all public health because it's community centric, right? So if you focus on a community, you're going to have to address everything else. It doesn't matter what your title is, you do everything else. And that, I feel like that's something that everyone in this panel, we have that in common, right? We do all community work. So thank you for having me.
Thank you, Doctor. And yes, I agree with you about this. And so thank you all. And I would really like to begin with a question about your perspectives on health equity in today's context. And I know we will be discussing and talking a lot about COVID-19 and post-COVID tomorrow, #teaser. But from the lens of social determinants of health and health equity, what are the lessons learned related to COVID-19, if any, that have helped reshape your thoughts about health equity and ways to address it through your work? Nia, would you like to start?
Oh, okay. So, I'm unmute. That's right. Okay. So for me, it's, I feel like the defining health equity, right? Because I feel like the answer for goal for health equity was always the same, right? We want having sufficient and appropriate resources in the broadest sense of the word to eliminate hepatitis B and TB. It's not a new goal. We've been in this for a very long time. So the hard question is, why are we still struggling with it, right? Over and over. I've been in this circle for 20 plus years and we're still asking it. And through Pacifica reflection, I feel like it seems we're getting away from the word, the true meaning of the word equity, right? It lost its meaning, its power, and its spirit. And we also stray from its truth, right? One of that truth is that equity does not mean equal or the same. The depth of our community problems are not the same. Social solutions and resources do not be the same. But on the other end, root causes like policy gaps, they're the same. So we should work together, and the nuances of inclusion, respect, and diversity should be re-examined. We must continue this hard but important conversation beyond this summit, right, on re-examination of bringing different people together, because I think one of the hardest things to take in is that as part of my community, we need to be part of the conversation towards meaningful solution versus the subject of the conversation, right? There's also discussion around tokenism, and it's very prevalent in these circles. People that want to represent us ended up tokenize us, right? Our communities, we do not want to be seat warmers, part of the brown face count. We desire and demand true engagement. So, back to your question, what are some of the, strategies, actions, and things like that happen? I feel like COVID-19 really did, elevate, our community to a different level of engagement, right? So during COVID-19, when they remember the time when they were trying to prioritize the vaccine, there were not enough vaccines, so everybody was fighting towards it or whatever else. Came to find out, like, priority population, Native Hawaiian Pacific Islander were not part of that. You know what I mean? So at every other group but Native Hawaiian Pacific Islander, that totally pissed us off. There's no other better way to say it than that, right? And the way that we addressed it is that we went through local communities and addressed it through their health department, because that's the direct source, right? Number one. Number two, we also look at data. So the reason why the government was saying we're not prioritizing, the data was not there. So we went to the source of data, have them pull it out, analyze it, and all that. Came to find out we were number one in everything. We didn't want a number one in it, but infection, deaths, and all of that, right? All of that came from community organizing and then actually going through the right channel and the proper way of doing it, right? So we went through that route, engaging our community at that level, but also forced us to move on the national level, right? Because if you really look at it, Native Hawaiian Pacific Islanders are not well organized on this national level, right? So it was time for all of us to come out of our silos and pockets and work together. And I feel like that is one of the lessons learned, one of something that we did successfully to address health equity and then social determinants of health. And when it comes to policy, with those success, there's one thing about having success. Success breeds success. In our community, we have so many deficits for a long time, right? So it kind of like pushed us down all the time until to the point where we felt helpless and all that. But going through that experience, our community were feeling, like, wow, we can do this, we can move forward. We call a national press conference. One of the lessons learned that we have, national press conference, we were even that organized. Our Zoom can only handle 200 people. We had 500 people, you know what I mean, register and come in and waiting in line. And then, and not just, usually we're like, oh, who's the, senators in our press conference or whatever else. We're talking our grandmas and grandpas, family members that were just coming on Zoom, and their grandchildren put their name as grandma and grandpa, you know what I mean? Because they didn't even know how to put that in. It was true community engagement. And yet on a policy end, all of the senators, representatives were there. They were very impressed with the number of people that are there, the engagement, and the type of people, right? So again, as success breeds success, we also learn the beautiful lesson of coming together as Pacifica people, and then also how to demystify policy, because in our community, we look at policy as the Wizard of Oz. You know what I mean? We don't know what's going on. We don't know where the Oz is. We don't even know how to get there, other than the fact that we're walking on this yellow brick road that we Pacifica people also contributed in building. So I feel like all of those wonderful things came out of such a sad period in our history of COVID-19. It taught us a very beautiful lessons. And I think that's the kind of lessons that we want to bring into the TB and the hepatitis B circle, because even this mistrust, the issue of mistrust of the vaccine or whatever else, it actually does not exist in a bubble. It actually flows out into issues like vaccination for hepatitis B, testing for TB, and all of those kind of things. So the lessons that we learned is like, let's just look at, be honest, ask the hard question, what went wrong and all of that kind of thing. That is a good thing, good place to start, but also look deep into our community for solutions and then move us forward to a better, future. Thanks.
Thank you, Dr. Itauto. I don't know who else from our panelists would like to.
This is Diane. I'd like to share as well. I think one of the things that kind of came out of COVID was that we were all afraid. We were all afraid at the same time. And it wasn't something that was just privileged to one group versus another group, that, oh, that group has maternal outcomes, but that doesn't necessarily impact me, or that group has specific behaviors, therefore, it's related to drug use or misuse, etc. But it was something that we were all on the same page, and it was a community-wide, a global fear. And with that fear, we started to see tangible losses of life, losses of personhood, losses of jobs, and we all experienced it at the same time. Now, I think what it also did was then it's when, as we saw the disease itself evolve and time go on, we started to see, oh my gosh, certain people truly don't have access to medication. Certain people or vaccines, certain people do have an increased likelihood because of their vulnerabilities. And we started to care because they were our grandparents, and we started to care because they were our neighbors. We also started to care because a good deal of us are at home, or those of us who weren't at home were so fearful as well. So that fear on a macro level, I really do think exposed us, and also exposed the gaps and the differences in lived realities, that even though some of us within the margins, whether it's persons of color or people with disabilities or people with different levels of education, et cetera, have been saying this, and interventions have been going on to address it, we didn't all have to sit down in our kitchens learning how to, new ways to bake bread and see it in real time. And we did. And I think it's unfortunate it has taken this degree of communal loss to do so, but I do think that this is an outcome. And it's been curious because over time, everyone has started to talk like an epidemiologist. Everyone's starting to use these new terms and, understands the difference between a pandemic and endemic and all of these things. But it didn't take until we had that shared loss that still some are experiencing on a disproportionate level to recognize that the differences in outcome truly exist and that there are interventions to address. So I think that that's a positive. It hurts so much that it had to hurt so much.
If I could just add to sort of this conversation around health equity, what does it mean? Maybe what did it look like during sort of this pandemic? I think one of the things that one of the things that we lost, right, during this sort of journey that Diane has definitely, which I agree with, shared in terms of our communal loss and our communal sort of increase of knowledge and awareness, is that for me, what we've lost is the fact that we're talking about a social justice issue, right? We're talking about the fact that health should be a right for everybody. It's a right, right? It's not a privilege. It's not something that we should commodify. It's not something that we should say, oh, well, if you do this, that, like, we negotiate. We really need to be thinking about health as a right for everyone. And what does that mean? That means that everyone at default level, at the basic level, has access, it's affordable, and it's available in the ways in which communities need it to be. And I think that, even before sort of the crisis, the COVID-19 crisis, that was something that wasn't really embedded unless you were someone who was working at those intersections of public health, health equity, and social justice. But now, even now, I think it's becoming lost because we have all this new interest in health equity without sort of that work, right? And being in the field and doing the work with communities. And so, folks are coming in maybe with good intentions, but good intentions could have, critical impacts, but maybe with good intentions, but totally missed the boat on how we need to be framing these issues, and really make it more about sort of this individual behavior, make it more about sort of, what can I do within the clinical system? But for me, it's a social justice issue. So when we talk about a social justice issue, we have to be talking about all these isms that make it challenging, right, to do this work, whether it's racism, whether it's sexism, whether it's heterosexism. We have to bring that into focus, even as we talk about building interventions. What I've enjoyed coming and sort of at this point right now is I am seeing funding that gives us the potential to really think about addressing those isms within systems and institutions, right? A recent NIH grant that funding that is out there called Compass, right? And so I think that, we need to get back to basics around what we really know and feel and hopefully and believe around people's right to health. And then understand that when we're talking about rights and justice, we're talking about these root issues, isms that are often the most hardest to change,
Thanks, Shioma. I think what you've said is a great also segue to base my next question, as health equity is commonly viewed, or some people view it through certain lenses and prefixed ideas like race and ethnicity. However, in reality, and what we've learned from the work that we do, from the previous discussions and the previous session, health inequity occurs across a wider range of dimensions. How does the meaning of health equity shift for different people and populations? And I would like to start with Dr. Poitier.
Yeah, thank you. Great comment. I'm going to bridge my comment for the last question and this one. I've been involved in the healthcare of people and populations for well over 20 or 30 years, at a time when terms like equity, equality, social determinants of health were not something that were banted about, but we lived it. We didn't have a name for it, but we lived it and saw it. And I think if I could say anything overarching is that our system is broken, and that every time a pandemic or an endemic comes along, it just exposes those cracks. I can remember back in the day when HIV first hit our shores, and the disruption that caused in the lives of healthcare providers and people. And then, currently, the system has not been designed really to take care of people. And what I've seen, and I find dismaying at this point, is the amount of misinformation that gets transmitted, the political intervention that prevents us from doing a good job for all people is quite dismaying. And I think that, all populations to some degree, mostly people of color and be it gender, experience some inequity. Some of it's buried and institutionalized. And I think the nice thing about it is that the words of social determinants of health, equity, are becoming well known, and people are taking the view that health is not just about coming to the doctor and taking pills. It's about someone's entire life, where they live, the safety, good food, good water, and I think that those are really nice things that I'm seeing, and that message has to be strong. And I think our elected officials, it was curious to me when I was in training, the idea that politics would guide care was something I never ever thought of. But in fact, good healthcare almost is a political issue, because certain policies can be made that really affect people very badly. And so I think when people say to me, well, I'm not political, I say, we don't really have the luxury to say that, because it just impacts everything.
So true. Thank you, Dr. Poitier. Any of our panelists would like to share their thoughts about this too? How do you think health equity differ with different populations and communities?
Yeah, within our Native Hawaiian Pacific Island population, so it's beyond racial or ethnic group and all of that. There's also geographic, diversity, right? Disparate, those that were in the city, for us is in the Pacific Islands, right? So our pandemic did not reach until like a month ago or 2 months ago, right? Because we closed all borders and all that. But by the time the pandemic hit, right, all the resources are, all the funding was dwindling anyway and all of those kind of stuff. So geographic boundaries also can be, they need some kind of equity issue, language, of course, immigration status, and all of that, right? So different immigration status, you have access to different resources because of your immigration status, sexual orientation, right? Even around workforce, right? In the beginning, like who was doing all the, with, medical services and all the way out, and they were getting all of the mask and everything else. But if you look at our community, who were the cleaners, right? Cafeteria, and they were not protected, right? So where you work also was an equity equity issue for us, so I feel like, you layer, what we always talk about with like ethnic group and racial, equity and all that, but there's all of these layers that's related to that made things a lot more complicated, right? So I feel like you need to address this in all of those arenas.
This
I
is
just-
Diane.
Go.
Oh, sorry. I'm in complete agreement. I mean, I frequently share, a story of how I grew up, and I am a child of, one parent who was foreign born and was limited English proficient. And like many kids, is pulled into, at that time at least, was pulled into serving as an interpreter. A child does not have the capacity and should not have the authority and autonomy to speak on behalf of a parent, nor do they actually have the capacity and the control of language to be able to do so. But often, that really was the case, and it was trends for a long period of time. But we think about the now, right? Even with laws and policies, and in some places executive orders that say you have to have a trained and competent interpreter. You think about it from a population lens with new and emerging populations, people who are maybe fleeing from war. Even if you think about the earthquakes that happened in Haiti over a decade ago, new terms were emerging that came as a result of the trauma that people were exposed to and experienced that there were not yet terms for. There also weren't interpreters that were available, nor were there clinical providers that could directly work with newer populations because the planning wasn't there, the resources weren't there, the recruitment, the training, the focus and the prioritization of diversification of the healthcare field. So it most certainly, when we're looking at health equity, it most certainly has, a lot to do with really population planning and trends and immigration and linguistics. But it also, before that, has to do with value. The value that we place on individuals and the healthcare that they should receive, the value on their lives, moving away from that belief that giving to one takes away from the other. But it also in making sure that our interventions match and are synced with the populations we're serving. Not saying you do this, your hands are dirty, you're not XYZ, but again, having those values. And our healthcare system, by and large, has not been open and valuing of other populations, of, non-English speaking, non-white, even body size and shape and how many people live in your household. Those all become places of blame and missed opportunity and harm.
Absolutely. Thank you so much for sharing this.
If I can just expand, because I really appreciate what Diane is bringing up in terms of looking at, in terms of community change, well, at least the way that I'm hearing it and processing it, looking at it in terms of community change and population change. And this is why I think when we talk about health equity, it's so critical that communities, I am personally trying to move away from this word of engagement and lean more on leadership. Communities, we have to be talking about communities leading these efforts, because communities know what they're going through at that moment, right? A perfect example is sort of, what's happening around TPS with various specific communities. I'm engaged in sort of the efforts around the Cameroonian community and the Liberian community. And so there's this thing about TPS that it could just be taken away at any time. And so you have communities that are in limbo for, 9 months to a year, literally in limbo. They have to leave their jobs. They can no longer operate as having a social security number. And so they're in limbo. They no longer have health insurance, particularly depending on what state you're in. And they, have gone through this traumatic shift in their lives, but the system is not capable of responding because the system is not looking at, or is not designed in a way in which is able to be that flexible and that nimble, right? And so when we have communities really centered and leading these efforts, we're able to create those policies and practices and processes that understand that population shift because of policy change, or just because we're doing life, right? Like life is life. That the thing shifts in communities and families' lives. And so I think that is a very, very critical, and sort of thinking about how we serving communities, not serving individuals, and how we think about the value that is brought when communities are really leading what needs to happen in this health equity space.
And Shioma, you always, for some reason, give me the best lead way to the next question, and really what you've mentioned is very important about looking at the community perspective rather than individuals. And as we think about ways to properly account for all aspects of care, direct and indirect, with health equity as a priority. In your experiences, what are innovative community-based strategies that helped you address social determinants of health and had an impact on improving health equity?
Yeah, you know, I can think maybe of a couple that I've sort of followed over the years, but I wanted to share more. When I was thinking about that question, I thought maybe, you know, for us to ponder more around what are the elements in which made them successful, right? And so when I think about it in that way, again, I'm going back to some of my previous question. Now I see how you're saying it's linked. Is that community leadership is essential, right? And when I talk about community leadership, I mean like who is making those critical decisions, making sure that, you know, community understanding, giving community the autonomy and the space to speak for themselves, and however way that looks and feels, right? It might be uncomfortable for some of us, depending on what position we hold and what agency. It might not sound like, you know, the English that we learned and you know, in school, right? So, you know, however that looks and feels. I think also as part of some of the interventions that I've seen that have been successful is that they are multi-pronged, right? We can't do this work thinking that we have one strategy and it's going to solve everything, right? No, it's multiple strategies that are part of a comprehensive approach that's going to allow us to address health disparities. So I don't want to totally eliminate what needs to happen at the individual level. I think unfortunately, we have a history of that being sort of our focus, right? Like 99% of the interventions that people develop are on that individual or group level, right? I think it's important, but for us to move further upstream and really thinking about what is sort of the other levels of intervention that we need to be doing. So I strongly believe that there is a multi-strategy approach at multi-levels. I think the other thing is understanding that we have to have different people at the table. If we're really talking about health equity, we're talking about intersectionality, not only intersectionality in terms of how people show up at tables, but also intersectionality in terms of issues, right? I can tell you the link between homelessness and unemployment, right? I know a lot of folks in here can do that, right? I can tell you the link between drug policies and HIV, right? So we have to think about these issues or these sectors in a very intersectional way. And that means that you might have to sit at the table with that pharma company, plus community partner, plus an academic, plus a policy, a government person. You know, you might have those partners that you all don't see eye to eye, but you're able to be honest in that space and be committed to engaging in a dialogue that gets to a common understanding and a common approach to address, right? So having multi stakeholders at the table from various sectors, I think is critical. And the last piece I would say in terms of when I think about what has made a couple of the community level interventions successful is that there is a commitment to a long-term partnership, I should say. It's a long-term partnership. This is not a 6 months to a year fix, right? We're talking about 5 years that people have been in it and doing it, right? So to change these systems and to really see social change. So we're talking about a long-term. What comes with long-term? We need long-term money. And we haven't seen that. We've seen siloed funding, funding that's based on a specific time frame, funding that only allows us to focus on one thing. But we need funding that allows us to be intersectional, and we need funding that allows us to build over time, right? So we need time to build those partnerships. Those partnerships just don't come up because we all are focused on, I don't know if I say, if we're all focused on HIV, that doesn't mean we're coming to the table with the same ideas and understandings, right? So we need that time to develop our partnerships. We need that time to develop what that intervention looks like. We need the time to implement that intervention and have those rapid assessments so that we can make it better and improve it. And then we need that time to just run the intervention and look at its impact and be able to assess and evaluate again from the lens of people who are most closest to the issues, right? So that's how I really think about what is successful in these spaces, and I'm sure people can add to that list. But I'll pause and hope and have my colleagues continue.
Awesome. Thanks, Chioma. Diane, you have something to say?
This is Diane. I'm in absolute agreement. I mean, I stopped and I thought, well, what has been the recipe for those interventions that I've really appreciated? And there's some pieces that are consistent, right? Like there's the language access piece. There's the priority in ensuring that populations are participating in the planning, right? But it's really before the delivery, before the execution, before the numbers that you're gathering at, early, intermediate, long term. It's really, have you sat down with populations? Have you indicated that you have some joint interest in this thing? Is this paternalistic? We're telling you must do versus, this is for greater good, et cetera. Has the population of focus communicated what their greater good is, right? So it really is before we get to that outcome and execution. And another piece of it is really, you may have to collaborate so much that your name isn't in big letters anymore. And a lot of funding sources, and I say this, coming from government, but a lot of funding sources or whomever is kind of the motor behind this thing don't like that. They want the name to be out there, but often you can't reach the population if they know that, who's leading the line is the government or the, whatever institution. You have to collaborate, and it still has to be a legitimate intervention, but it's legitimate because they're participating at onset, because they're infused, they're through and through, part and parcel, but your name may not be in big letters. And I do think that can impact, funding, right? They want to give you seed money. Seed money needs water money, needs dirt money. It needs all of these things so that it can grow and expand and it can truly change, outcomes over time. But I do think a lot of that is at play.
I just feel like I want you to make that a t-shirt. I don't know. I guess when you did that, I just didn't even know how to type. I didn't know what to do. That is definitely a t-shirt.
Dr. Poitier, what do you think?
I just fantastic comments. I think that the only thing I can add is how important advocacy is and keeping your voice loud so that people hear. I mean, Leah is absolutely correct. As a person who responds to data and recommendations from the larger organizations such as the CDC and the state, we were absolutely shocked at the end when we found out that Pacific Islanders had, the increased risk and death that they did. But that data didn't come to us until late. And that data wouldn't have come to us had it not been for advocacy. Sometimes, unfortunately, there's such a myopic view of looking at any problem. It's so important to keep voices diverse and engaged. Sometimes it's just, the loudest voice gets your attention, and because you do have limited resources. So I think that the strategies that work are situations like here, keeping the information and the advocacy loud and strong so that organizations don't forget. It's like, hey, yeah, we're here. Don't forget us. We experienced this. Like with COVID, like you said, the workers who didn't have the option to work, who didn't have the option to telework, or who didn't have sick paid leave, were some of the hardest hit. So I think that would be my addition to the conversation there, that the advocacy, loud voices, strong community engagement is just essential.
I'm in full agreement with what everyone was saying, and then to end it off, I was thinking about, I think trust was a major issue, right? Because they were saying, well, we didn't trust their vaccine. Well, they didn't trust us with 10-year funding. I think one of the reasons why they're holding on to this short-term funding is like 1 year, see if we trust you. You know what I mean? It's one of those doling it out slowly, right? So I think there is a trust issue on both ends, right? We don't trust them, they don't trust us, but how can we build that? What can we do to build that trust? Because there were a lot of things going on. We learned a lot of lessons in agreement with all of that, setting a space for us to be there and also give us time in that space. Don't give us the space and tell her get out in an hour, right? Because that's when conversations start, right? 2 hours later, true conversation will start, right? So all of that is trust building, right? So however we want to move forward with this TB and hepatitis B or whatever else, let's continue building that trust both ways, right? And then all the things that was mentioned earlier, they actually going to help us continue building that trust. Those are very trust building activities and goals. So I'm really glad that we're having this conversation.
Great perspective. And I can't really have all these experts in the room and can't ask about synergism and the benefits of collective action. And in your work and experiences, how can the work you're doing to improve health equity and address health equity issues can benefit the different population groups? Chioma mentioned before that there is a lot of intersectionality between health issues at the community level, and different populations are impacted by through the intersection of all these dimensions. How does the synergism and collective action benefit the different populations? There is a population affected by hepatitis B, TB, AIDS, HIV/AIDS. How can all the work that you are doing benefit all of these people?
Well, I'll start. As a public health department, that is our primary goal. We are not care for primarily, equity challenged or economically challenged. We are healthcare for all, though we tend to be more involved in those who have fallen through the safety net. But I think the entire role of public health, of course, is to provide safety and care for the population in all areas, be it infectious diseases or even chronic diseases that we're involved in. It's often said that the work of public health, if done correctly, is invisible. And usually only when a situation like this comes to light that people realize that the public health department is involved. But one of the problems with the public health department, with every public health department, is just chronic underfunding and chronic understaffing. But I think one of the ways we get around that is that we partner with our community partners strongly and work very closely with community partners, because we say that the work that we do, we can't do it alone. We need community involvement in all areas. So I think keeping a strong link with your public health department and we keeping a strong link with our partners is one way that we help out. And we're involved in all things that people don't even realize, be it testing oysters at the ocean. Most people know us for the letters on the restaurant, A, B, and C, but we are actually involved in so many aspects of everyday life, which we're proud of. And it's our goal to continue that. And
Thank you for that work. Diane, how does the work you do benefit from a collective actions, from synergism, the syndemic program, benefit people with hepatitis B, people impacted by TB?
Absolutely. So I think what government can do And again, that's just my background. But I think what government can do, and what in some spaces has started to do intentionally, is require that when there's a release of dollars, that there is cross collaboration across, organizations or agencies on the community level that deliver direct care, that are representative of the populations, organizations that may be able to serve as a fiscal conduit, organizations that may have some link to, education, academia, etc. And I think that there's true value there. One is that there have been chronic underfunding of community-based organizations, or community, directly working within the community organizations. In part, when you don't get the funding, you don't get to show that you have the history of delivering the intervention so that you can get more funding, right? So it's an obstacle that's at onset, and a lot of organizations can't, they aren't ramped up to do that yet. So then, even though they have the smart idea, they have the population touch, they have, all of the things, they just don't have that quote unquote history of success. So I think that cross collaboration creates an entry point. It creates an opportunity for it to be replicable, right? And for there to be, again, true value focused on this is what's been able to happen. And again, I do believe that it can happen through those collaborations. And sometimes they feel very forced. When you're writing a grant and you have to make friends with somebody down the street because you need a fiscal conduit, it feels quite uncomfortable. It feels very, very uncomfortable, especially when the conduit says that they want 15% or more, right? Very big sad face. But the truth of the matter is that there are ways to then start to establish and solidify and really codify that we need each other. Hi, bank, I know we need you, but you also will have more people walking into your bank. You also have more people who are experiencing financial literacy over the long run. You also have improved and enhancements to people getting home ownership, et cetera. And that feels very separate from health interventions. It is not, and we start to learn that over time. So I think that there's absolutely true value, but we have to recognize that there's some discomfort in starting to make those collaborations. It's not everyone at the table eating something from your country. Like, it really can be quite uncomfortable in the beginning and over time.
Yeah, if I can just add on what my colleagues are saying, I think in speaking from as a grassroots community-based organization, and for me, being able to create approaches that are funded to look across pandemics supports communities and not being overly burdened, right? Like, we know that we are dealing with, as someone who represents a community that's dealing with a lot of inequities, like, we know that, okay? We don't need somebody coming in telling us that, what's the list of health disparities or health inequities we're dealing with. Like, we know, right? And so being pulled in places where, okay, over here, let's deal with HIV, over here, let's deal with TB, over here, let's deal with hepatitis B. And as a community-based organization, it's critical that we're in all those places, right? Especially as a community-based organization that is the only Black-led organization, HIV organization in New England. And I'm not just talking about Massachusetts. In New England, we get calls from all kinds of folks wanting us to be partner on this, do this. And, we're thinking, okay, how do we work with our community to be engaged, but not to be stretched and overburdened? Because folks got to live life. Folks got to go to work. Folks are in school. Folks are doing, cultivating families. So I think, from my lens, it's like, let's all come together and create an approach that allows us to look across and address across, because what makes the inequities in HIV are the same inequities that we're dealing with in TB, the same inequities that we're dealing with in hepatitis, right? It's just showing itself differently because of the disease of focus. So I think it's critical that we do, again, think about the burden that it creates on communities and community-based organizations that are doing the work when we have these multiple splits and these silos as a part of trying to address these issues.
For me, it's, in funding, right? So they, it's very silo. You get diabetes here, you get cancer here and all that. Community, they look at the whole person, because you cannot leave cancer on the side and leave your diabetes. You cannot leave your hepatitis B here and do all of these things. So I feel like in moving forward, even though you're getting funding for TB, hepatitis B, cancer, whatever else, be mindful that community always look at the whole person. So don't ask like, okay, and especially now with COVID-19 funding, right? Because that's the funding we have right now. There are how many COVID-19 or whatever. Well, we did hepatitis B on the side because that's what they were asking for, right? Have like for funders to have that holistic approach. Yes, we are gonna, the primary is this, but we are gonna let the community, right? Just, and let is what they use, right? Let the community use that for this and that, like our other priorities, right? Community know what to, community, they know what we need. We know how to use the resources wisely. We know how to do it. Just give us the trust and the freedom to do it, and then you will see better results. Because a lot of time they hold our hand, and then when they read our report, you didn't do any of this because you did not let us do what we wanted to do, and that's why the reports look like that, because you tied our hand and trying us to solve this. If you just let us do our work, both of us going to benefit, like the funder, us, our community, and all that. So I feel like that can be something that we move forward, not only working together across, diseases, funding, and all that, because community look at holistic issues, not just an individual problem. So I feel like that's what we can do in our communities, but then that can be also something that we do across, right? Because you're now at the table with so many ethnic groups, disparity groups, and all of those kind of things. We all come from the same spirit of we want to do something that is, that's going to move all our communities forward, right? We're starting with that, and working together will help us get to that end.
Great perspective, and I 100% agree and totally agree. So the question is then becomes, and this for all of you, what is the long-term goal for health equity in the for tuberculosis and for hepatitis B?
Well, say, for the public health department, the importance of equity, social determinants of health, and equality has been increasingly recognized by our executive staff and our board of supervisors. And they've committed a great deal of funding as well as staff towards that goal. Every public health department is organized differently. So here in California, we're definitely organized differently than in Massachusetts or New York. But the community focus is huge now. And for example, our TB control program, since this is a conference, looking at TB and hepatitis B, we have an entire division, of course, that looks at TB and equity and treatment. And using advanced technology in tracing and identification of cases and an acknowledgement of the social determinants of health, I think we're having much more impact in terms of finding people, identifying people, treating people, and bringing them into therapy. And our hepatitis B program as well. So for us, the future, I think, looks very bright. I mean, I'm very happy to say there's been a recognition of the importance of equity, equality, and social determinants, and that these two diseases, particularly TB, and hepatitis as well, disproportionately affects people of color and poor people. And we're prepared to address that.
Thank you, Dr. Poitier. Anyone else thoughts to share on this? So my last question is, and I was keeping this time permitting, is in this day and age, like with the technology, with the all the programs at the grassroots level being provided, what do you have to say about equity in access to information and knowledge and awareness and education. What are your thoughts about this? We always think about health equity from the lens of actually providing care or providing services that are related to the care, like language, like transportation. What about the access to information and knowledge?
Yeah, I think there's parts of that question that we sort of digged into a little bit. I think, in a public health sort of sense, that lends itself to health literacy, right? And really thinking about how health literacy is a social determinant of health. So basically, how people access information, how once they get that information, they process it, how, as part of that process, they make an informed decision, right? All of that is based on how what information systems are releasing, right? And how that information is being released. And so I think for me, we've talked about, Diane has brought in sort of language, the various complexities of language, that is just not that sort of word for word translation. It's not just the fact that you could speak the language. We can get into sort of, the dialects of languages, right? The French that's spoken on West Africa is a different dialect than the French spoken in Haiti, right? Like, so, and it's very noticeable, to people who have that ear, who are paying attention. So I think when we talk about sort of information, it's critical for us to say, what is the best way in which this information can be given and received for communities? That's going to look different for all the communities that, we're talking about, right? When I think about African immigrants, a lot of the work that I was doing at the beginning of when I started, and I still do, is using proverbs as a way to talk about HIV prevention, care, and treatment, right? Proverbs are very common across African cultures. My father can have a whole conversation with my uncle in Proverbs, right? Like, and so it's a way to tap into culture, but it's also a way to understand that we have our own wisdoms in our communities. And so we can build and utilize those wisdoms to do the prevention and care and treatment and policy change that needs to happen. I have a colleague in Massachusetts, Naima Aglab, who taught me a lot about how the Quran supports actual sexual health, right? How the Quran supports me doing HIV prevention work with African Muslim communities, right? So, the fact that we think about communities as sort of this deficit and not, really thinking about, I'm moving a little bit away from the question, but about it as a deficit and not really thinking about the wisdom and the assets that communities already bring, is a barrier in us even being able to do health equity, and think that there are other ways to know. There are other ways to share information versus flyers and an email and a text, right? I'll pause there. I know other folks have something to say.
You're not drifting away. You're actually at the heart of the question. Thank you for bringing all these aspects. Perfect.
Yeah, for us, every time there's a solution, 200 other problems come along, right? Because during COVID-19, they were like, we need to get the information out. So the federal government invests a lot of social media, all the influencer, all of those kind of things. But at the end of the day, a lot of our community, those are not their influencer, right? We don't go to social media for that kind of information, right? So we also got to look at what type of information we want to get out, because we don't want bad or wrong or false information out. We saw all that played out, right? When all of this, and who's determined whether it's false or whatever, there's wisdom that needs to go in there. So the conversation then within our community, those conversations were very, very important, because we have to decipher because all this information is crowding and noisy at that point, right? Because all of it was coming down at the same time, and our community have to figure it out on their own, like which is good, with bad, or whatever, should we get vaccinated, not, or should we trust this person or whatever else. So with everything about information, it all then circle back into the community, right? Our own, give us the space, our own discussion. Who do we trust? You know, what was our experience and all of those kind of things. So at one point, then they were, you know, we're like, well, we give you this money for this. And we're like, well, no, thank you, because we want our space to have that conversation versus relying on all these social media and that kind of thing, right? So there is a, you know, all of those things, they're important, you know, they also, you know, are useful, but use it the right way, right? So they're all tools, but we have to use it the right way. And then our community have to have the space, the knowledge, the wisdom, and the space to decipher it and use it for our own good. So I think that's something we're asking for, right? That space to have that, you know, to decipher all of the information.
So true. Thank you, everyone. I'll now hand it to Evelyn Moa from APCHO and Maria Fernanda Gutierrez from the Asian Pacific Islander American Health Forum to take us to the next phase of this session, and then we'll come back.
Hi, thank you so much, Yasmin. Hello, my name is Evelyn Moa, and I serve as the Associate Director of Chronic and Infectious Disease Initiatives at APCHO. I have the pleasure of introducing today's breakout session. In today's breakout session, you will have 30 minutes with a panelist to discuss one of two topics. There will be 2 rooms per topic that will be facilitated by one panelist and a note taker. One topic is on health equity in today's context, and the second is on community-based strategies and social determinants. In the health equity in today's context breakout rooms, we hope you will take into consideration health equity in today's context, how the meaning of health equity shift for different people and populations, and long-term equity goal in the TB Hep B space. And in the community-based strategies and social determinants breakout rooms, we hope you'll take into consideration community-based strategies and actions that were successful in addressing health equity and social determinants, how social determinants of health impacts our communities and long-term equity goals in the TB Hep B space, including anything else that was brought up here in discussion with our panelists. At the end of the 30 minutes, we will all come back together in this large room for a report out to hear what was discussed during your session. But before breaking out, we'll have a brief transition for everyone to grab water, use the restroom, select your breakout room, and get situated. And if you need help transitioning, please go to the participants list and message anyone with the Ask Me that you see in front of their name. They will help you to transition to the room of your choice. So now, and before we break out, I would like to hand over the virtual mic to Maria to share more information.
Thanks, Evelyn, and thank you, panelists, again for agreeing to be part of this really powerful conversation. My name is Maria Gutierrez. I'm a steering committee member with the TB Elimination Alliance, representing the Asian and Pacific Islander American Health Forum. I was absolutely honored to have been able to share this space with all of you today. You know, when we were planning this session, what we hoped to do was to facilitate an open dialogue about the implications and recommendations for achieving health and racial equity in communities who've been disproportionately affected by TB and Hep B. And now, you know, with the grace and dedication of our panelists, we've been able to gauge insight into these lived realities that each of our priority populations encounter when faced with these diseases in the United States. But before we broke out, we wanted to clarify the language to some degree and establish common ground about the concepts that we'll be focusing on in the breakouts. The key ones being the contrast between socially determined versus structurally determined barriers to health. And the most simplified analogy I could come up with to help distinguish these two was this idea of the apple versus the tree, where the apple or the community will inevitably mirror the health of the tree, which is to say that the social determinants are those nutrients, those conditions that determine its disposition. In the real life, these are things like language access, transportation, the built environment that predisposes communities to poor work and living conditions, limits their access to specialty care or preventative services, and just creates this vicious cycle of chronically unaddressed, underdiagnosed, and undermet health needs. And so the structural determinants are the roots of the tree, which determine how tall it grows, how long it lives, how fruitful of a life it will have. And it's important, I think, to acknowledge too, in defining these, is that structural barriers essentially is the ways in which society has manifested discrimination and disparity through systems reflected in history, culture, and institutions. So as champions for health and racial equity in TB and Hep B, we want to start thinking about how to inspect, acknowledge, and evaluate the depth of those roots for each of our communities. Because it's only by understanding those mechanisms that we as healthcare professionals will be able to know what kind of resources the tree needs to thrive, because they're all different. It grows in different climates at different rates and exposed to different species. So we need to make sure that we get the formula right, because we've seen what happens to communities when we don't. It proliferates this collective sense of fear, violence, and racism that prevents communities of color, like the NHPI, Latino, and African American communities, from seeking health care, from trusting providers, or adhering to treatments and follow-up care that is impractical and inconsiderate of their life circumstances, which is why we're really looking forward to this interactive community discussion. Because frankly, I think we need to be having these conversations more frequently in order to shift this paradigm and adopt more equitable healthcare practices for communities who've been systemically vulnerable to these diseases throughout history. Because I think I'm going to echo Jeff in his introduction yesterday. We're all tired. The task of achieving health equity is, an ultra marathon that just requires patience to learn, discipline to guide others, tenacity to enable communities, and leadership to advocate for those better outcomes and better policies. So we want to really encourage each of you to feel empowered to share your thoughts and use this space in a way that will be fruitful to you, your communities, and the work that you do, so we can start learning to grow better trees and healthier communities. And so, with that said, thank you again for choosing to engage in this space with us. And I think we're going to go ahead and take a quick 10-minute break, and we'll see you back at 10.